Imagine your home security system just gets tripped. Like a burglar breaks in, the sirens start blaring, the police are called, and the burglar is chased out of the house.
Right.
So the threat is entirely gone. But the alarm, it just never stops ringing. The siren just blares at top volume day and night for months, maybe even years.
Yes.
Now, I want you to imagine that alarm is happening inside your own body.
Yeah, it's a genuinely terrifying scenario. I mean, usually when we seek out a medical diagnosis, there is this very comforting expectation of precision, you know?
Yeah, exactly. Like it's straightforward.
Right. You break your arm, the x-ray shows the fracture, the doctor points to it, and you get a cast. It's visible, it's binary.
But then you step into the world of chronic pelvic pain, and suddenly that x-ray machine is just useless.
Completely useless.
We're looking at a diagnostic landscape that is, frankly, incredibly murky and leaves so many patients feeling like they're literally losing their minds. Today, we are wading right into a medical mystery that confounds both patients and doctors alike. We're talking about persistent, burning pelvic pain.
Right. Specifically pain with intercourse or insertion, which is known clinically as dyspareunia.
Yes, dyspareunia.
It is honestly one of the most profound challenges in gynecology and pain management today, because the symptoms present themselves in a way that is incredibly deceptive.
Okay, let's unpack this. We are looking at a core question that so many women face. When is a burning pelvic pain just a really stubborn, recurrent yeast infection, and when is it actually a permanent structural change to the body's nervous system?
That is the million-dollar question.
Right. So we're going to map out the actual clinical tracking metrics you need to figure out if you are dealing with a fungal overgrowth, which the medical community calls recurrent vulvovaginal candidiasis, or RVVC.
Or, on the other hand, a localized neuroproliferative cascade known as provoked vulvodynia. And to do this, we're looking at a stack of really compelling sources today.
Yeah, we've got clinical guidelines, qualitative patient studies, and some truly fascinating histopathology research from journals like Pelvic-Radiology.
What's fascinating here is the core paradox at the heart of this issue. You have countless patients who are repeatedly told, they just have recurrent thrush.
Just thrush, right.
Just thrush. They are handed antifungal cream after antifungal pill. Yet when clinical researchers actually examine the tissue of women with chronic provoked pelvic pain, the biology tells a completely different, purely neurological story.
To understand how this happens, we have to start at the baseline, which is the fungal illusion itself. Let's define what a normal, albeit highly annoying, cycle of recurrent yeast actually looks like before we can see how it tricks the medical system.
That makes sense. So looking at the clinical guidelines, like those in the UK, they define recurrent vulvovaginal candidiasis, or RVVC, as having 4 or more episodes of thrush in a 12-month period.
4 times a year, that's a lot.
It is, and crucially, at least 2 of those have to be confirmed by a lab, like with microscopy or culture.
Okay, and that acute episode usually presents with a very specific profile, right?
It does. You typically see vulvovaginal itching, soreness, and that classic curdy discharge.
Right, the hallmark signs.
Exactly. Although, and this is a really key nuance, in chronic cases, that discharge might actually thin out or just vanish entirely.
Oh, wow, so it changes over time.
It does. But fundamentally, RVVC operates on an infectious disease model. A fungus, typically Candida albicans, overgrows. It causes inflammation. You take medication and the fungus dies off, the inflammation recedes, and you feel better.
Until it happens again.
Right, until the cycle repeats.
So you find the bug, you kill the bug. But then we introduce this secondary condition, provoked vulvodynia, specifically secondary localized provoked vestibulodynia, or LPV.
Right, LPV.
And the defining characteristic here is not an itch. It is this extreme symmetric sensitivity at the vestibule, which is the entrance to the vagina. We're talking about a burning, stinging pain that is strictly provoked by touch.
Any kind of touch, really.
Yes, sexual intercourse, inserting a tampon, or even wearing tight jeans can cause severe agony.
And this is where the infectious model and the pain model collide in a really, really treacherous way.
How so?
Well, when we look at the clinical data in animal models, like the research done by Farmer and colleagues, chronic candidiasis is frequently implicated in the onset of this secondary pain syndrome.
Wait, really? So the yeast actually causes the pain disorder?
Yes. The repeated fungal infections and the persistent intense inflammation they cause, they actually act as the catalyst for the localized provoked vestibulodynia.
Wait, so let me make sure I've got this timeline right. The fungus is essentially the match that starts the fire, But treating the fungus doesn't actually put the fire out.
That is the exact mechanism at play, yes. Going back to your opening analogy, the yeast is the burglar that triggers the alarm system.
Right.
But the persistent inflammation physically damages and alters the alarm wiring. So even when the antifungal medication chases the yeast away, the pain receptors are fused in the en position.
Which means the patient is just trapped.
Completely trapped.
I was looking at this qualitative study in the British Journal of General Practice that perfectly described this trap. They call it the candidacy framework.
Yes, the candidacy framework. It's a huge issue.
Because a patient has this long history of yeast infections, the moment they feel this new, intense burning pain, their brain, and frankly their doctor's brain, immediately defaults to the old familiar enemy. They assume the burglar is back.
It creates a vicious cycle of what researchers call recursivity. Patients go back to the clinic, they report a burning sensation, and the clinician, seeing a chart full of past yeast infections, reflexively prescribes another round of topical or systemic antifungals.
Just on autopilot.
Basically.
Yeah.
And researchers like Lusing explicitly warn against this clinical reflex because repeatedly bombarding the tissue with harsh antifungal treatments before ruling out a primary pain condition, it severely delays the real diagnosis.
Not to mention the psychological toll of all that. I mean, you're basically hunting a ghost burglar while your quality of life is being destroyed by a blaring alarm. And the treatments aren't doing anything because the target's just entirely wrong.
Exactly.
So let's look at the hardware change itself. How does inflammation actually breed new nerves? Because this isn't just psychosomatic. The pain isn't, just in the patient's head.
Oh, not at all. It is deeply physically structural. The medical term for this physiological change is neuroproliferation.
Neuroproliferation.
To understand how a simple yeast infection turns into a structural nerve disorder, we have to look at the peripheral neurologic mechanism.
Break that down for us.
Sure. So when you have chronic repeated inflammation from yeast, your immune system continuously deploys first responders to the area, and these are your mast cells.
Right, mast cells. The immune system's frontline soldiers. But instead of just putting out the fire, these mast cells start doing something else if they stick around too long, right?
They do. When mast cells are chronically activated, they sort of panic. They start releasing a heavy cascade of chemical mediators into the surrounding tissue.
Like what kind of chemicals?
Two of the most crucial ones for this process are nerve growth factor, or NGF, and an enzyme called heparinase.
Okay, nerve growth factor sounds pretty self-explanatory. It's signaling the body to grow more nerve tissue.
Exactly.
But what is heparinase doing in this equation?
Think of heparinase as a biological bulldozer.
A biological bulldozer. I like that.
Under normal circumstances, you have this layer of connective tissue, the basal membrane, and it keeps your deep nerve fibers separated from the very top surface layer of your skin, the epithelium.
So there's a physical barrier.
Right. But heparinase, that enzyme from the mast cells, it breaks down that connective barrier.
So you have nerve growth factor hitting the gas pedal on rapid nerve growth, and this bulldozer enzyme just clearing the path.
Precisely. It allows these newly proliferating pain fibers, which are called nociceptors, to physically migrate from the deep tissue, penetrate the basal membrane, and travel all the way up to the surface epithelium.
Here's where it gets really interesting. How do we actually know there are more nerves? Is this just a working theory based on patients saying it hurts?
Not at all. There is hard, objective histopathological data on this.
Objective data, okay.
Journals like Pelvic have published studies where researchers took actual tissue biopsies from the vestibule of women with provoked vulvodynia and compared them to healthy controls.
They actually biopsied the tissue.
They did. And they use highly specific chemical stains like S100 and PGP 9.5 to illuminate the nerves under a microscope.
Okay, so what does that PGP 9.5 stain actually show?
It specifically lights up the absolute thinnest sensory fibers known as unmyelinated C fibers.
Unmyelinated. That means they don't have that protective sheath, right?
Correct. To put that in plain English, unmyelinated means these nerves lack a protective myelin sheath. They have no insulation whatsoever.
So they are just raw, exposed wiring.
They're completely raw, exposed wiring.
Yeah.
And the findings under the microscope are just staggering.
What do they find?
The density of these raw nerve fibers in the tissue of women with provoked vulvodynia is 10 times greater than in healthy controls.
10 times. 10 times the normal amount of pain receptors.
Yes. And because of that biological bulldozer, heparinase, those unmyelinated C fibers have penetrated more than 50% of the distance to the mucosal surface.
Oh my gosh.
They are basically sitting right at the very surface of the skin, entirely unprotected.
If we think about how that translates to the patient experience, I mean, it's an incredible validation.
It really is.
If someone has been told to, just relax during intimacy, or that the pain is just anxiety,
Yeah.
you cannot outthink 10 times the normal density of raw pain fibers.
You absolutely cannot. If we connect this to the bigger picture, this massive structural hardware change is the textbook definition of a phenomenon called allodynia.
Allodynia. Okay, define that for us.
Allodynia is when your central nervous system interprets a completely benign stimulus, something that shouldn't cause pain at all, like a light touch, a cotton swab, or snug clothing. It interprets it as excruciating pain.
Because the nerves are literally right there.
Right. The nerves are so numerous and they are so dangerously close to the surface that the nervous system is literally screaming in agony from just a gentle touch.
So, if the hardware of the body has physically changed this much, you clearly can't use the old diagnostic software to figure out what's wrong.
Exactly. You need new metrics.
Which brings us to the most practical part of our deep dive, the clinical tracking journey.
Yes, this is crucial.
If a patient is trying to break out of that candidacy framework, how do they, alongside their doctor, draw the line between a stubborn fungal infection and a neuroproliferative cascade? Let's walk through how a diagnosis should actually unfold based on the metrics.
The very first clue actually happens before the patient even gets to the clinic. It comes down to symptom quality and timing.
So tracking your own symptoms at home.
Exactly. This requires becoming a very keen observer of your own body. If you are dealing with a fungal infection, RVC, the predominant classic sensation, is a distinct itch.
An itch.
Right. And interestingly, those symptoms often fluctuate with a woman's hormonal cycle, frequently improving during menstruation.
But if that inflammation has actually caused neuroproliferation, the vulvodynia is going to feel entirely different.
It rarely presents as an itch. Patients describe it as a severe burning, a rawness, or like a stabbing sensation.
Burning and stabbing, not itching.
And crucially, it is strictly provoked by pressure. If nothing is touching the vestibule, the patient might feel completely fine. But the most defining timing metric of all is something called the after sensation.
Let's focus on that for a second because it seems like a massive differentiator. What exactly is an after sensation?
Well, with nerve proliferation, after the provocative touch ends, say after sexual intercourse, the burning pain doesn't just stop. It continues to echo for hours, or in severe cases, it can last for days.
That lingering burning echo. So if you are tracking your symptoms in a journal and you notice a severe burn that sticks around for 2 days after intimacy, that is a giant red flag that you were dealing with altered nerves, not an active yeast overgrowth.
Absolutely.
Okay, so the patient notices the burn, they go to the doctor, and the doctor pulls out a swab. This seems to be where a lot of misdiagnoses happen.
It is the ultimate diagnostic trap. The standard clinical protocol for suspected fungi is a high vaginal swab.
Right.
The clinician might do a wet prep using a potassium hydroxide solution to actually visualize budding yeast cells under a microscope right there in the office, or they might send it to a lab to culture it on a specific medium like a sabrod plate to see what species grows over a few days.
Which, I mean, that sounds incredibly definitive. If the lab culture comes back positive for yeast, you obviously have a yeast infection and that's what's causing the pain, right?
That is the assumption, but it is deeply, deeply flawed.
Wait.
This is a massive caveat that both patients and doctors must understand. Between 10 and 20% of completely healthy, asymptomatic women will test positive for Candida on a vaginal culture.
Wait, let me get this straight. You were saying up to 1 in 5 women just naturally have this yeast hanging out and it's doing absolutely no harm.
Yes, they are colonized by the yeast, but it is not causing an active infection or an inflammatory response.
So if a patient has severe burning pain because their nerve endings have proliferated tenfold and they go to the doctor and the doctor swabs them, there is a 20% chance that swab comes back positive for yeast just by pure coincidence.
Exactly the problem. A positive culture without the classic fungal-specific symptoms like the distinct itch and the curdy discharge, that positive culture can be a total red herring.
Wow.
But because doctors are busy and a positive lab result feels definitive, it sends the clinician right back down the path of prescribing more antifungals. Meanwhile, the true driver, the neuroproliferative cascade, goes completely ignored.
That is infuriating.
It is.
But also, incredibly empowering to know. Because you can't just blindly trust a piece of paper from a lab if your symptom profile screams nerve pain.
You really can't.
So if a high vaginal swab can't be trusted to diagnose the pain, what physical test should a doctor be performing?
The gold standard clinical metric for provoked vulvodynia is remarkably simple but highly effective. It's called the cotton swab test.
The cotton swab test, how does that work?
A clinician takes a standard moistened cotton swab and uses it to gently indent the vestibular tissue.
Just a normal cotton swab.
Yep. And they are applying a tiny amount of pressure. We are talking only about 5 millimeters of indentation. They will systematically test several specific locations around the labia, the introitus, and the hymenal remnants.
Are they looking at a specific area?
They pay particular attention to the posterior areas, sort of the bottom half of the vaginal opening.
And what exactly is that tiny bit of pressure supposed to reveal?
It provides physical proof of that allodynia we discussed earlier. In a patient with provoked vulvodynia, that gentle 5 millimeter pressure will elicit severe, sharp discomfort or burning.
Just from a cotton swab.
And here is the kicker. It will cause that severe pain even when the tissue looks completely normal, pink, and healthy to the naked eye.
No rash or anything.
There is no rash, no swelling, no obvious inflammation to see. But the patient's reaction to the swab is intense. If you flinch from that simple touch, you are almost certainly looking at a structural neurological issue, not a surface infection.
Okay, so we have symptom tracking. We know to be wary of asymptomatic swab cultures.
Right.
And we have the physical cotton swab test. But there was one more metric to look at, and it involves the medication itself. Sometimes the way your body ignores a drug is the best clue to what is actually going on, right?
Oh, absolutely. This metric is about recognizing the failure of suppressive therapies. For a patient with a confirmed stubborn recurrent yeast infection, a doctor might prescribe a heavy-duty induction regimen. This typically involves a systemic oral antifungal, like fluconazole.
Right.
The patient takes a 150 milligram dose on day 1, day 4, and day 7.
That is a lot of antifungal firepower.
It is a massive dose. If a patient completes that full aggressive regimen and their burning provoked pain does not abate in the slightest, the clinician has to stop and reassess.
Right, because if it was yeast, it would be gone.
Exactly. If the symptoms completely ignore the fluconazole, it strongly points toward the pain being driven by the altered nervous system. The burglar has been thoroughly evicted, but the alarm is still ringing.
But we have to be careful here, right? Because biology is rarely simple. Is it possible for a patient to have both the burglar and the broken alarm at the exact same time?
It is highly possible, and I encourage everyone trying to solve this mystery to think critically about coexistence. The presence of a legitimate symptomatic yeast infection does not magically mean your nerves haven't also proliferated.
They can happen together.
You could have RVVC that triggers the mast cells, causes the nerve growth, and now you have two overlapping conditions.
Which makes tracking so vital. You might take the fluconazole and maybe the surface itch goes away, but the deep burning pain on contact just remains.
Right.
That's why you have to track the difference between an itch that responds to medicine and a provoked pressure pain that lingers for days.
It's just the subtle but vital difference between an active infection and an altered nervous system.
This has been an incredibly eye-opening journey. Let's sort of recap the biological shift we've explored today.
Sure.
We've learned that recurrent thrush isn't always just a localized annoyance that you treat and forget. In some women, the chronic inflammation acts as a catalyst.
A very powerful catalyst.
It forces panicked mast cells to release nerve growth factor and the bulldozer enzyme, heparinase. This literally rewires the vestibular tissue, pulling unmyelinated sensory fibers to the surface, resulting in 10 times the normal amount of raw pain receptors.
And because of that structural shift, you cannot rely on old infectious disease frameworks to diagnose this new reality.
You just can't.
You have to track specific metrics, monitoring for the prolonged after sensation of burning, recognizing that a positive yeast culture might just be a harmless colonization red herring.
Yep, yeah, 20%.
Utilizing the gentle pressure of the cotton swab test, and flagging when heavy-duty antifungal regimens simply stop moving the needle.
It's all about taking the power back through your own physical data. But before we wrap up, there is one more layer to this mystery that I want to touch on.
Okay.
If the fungus is the match that starts the fire, why does only one house catch fire? Like, why does a yeast infection cause 10 times the nerve growth in one woman, while another woman with the exact same severe yeast infection experiences zero permanent nerve changes.
This raises an important question, and it points to the very future of how we understand and treat this kind of pain.
Where's the research pointing?
The research indicates that the answer likely lies in our DNA. There appears to be a genetic predisposition to this exact type of neuroproliferation.
Wait, genetic? So some women are just born with a higher risk of growing these extra pain nerves.
Yes, researchers have identified specific genetic variations known as single nucleotide polymorphisms, or SNPs.
SMP.
They found these variations specifically in the NGF gene, which we know controls nerve growth, and in the TRPV1 gene.
What does the TRPV1 gene actually do?
The TRPV1 gene is fascinating. It provides the instructions for making a specific receptor in your body that detects heat and pain.
Heat and pain.
It is actually the exact same receptor that is activated by capsaicin, which is the active ingredient in chili peppers.
Oh, wow. Which perfectly explains why the pain is constantly described as a severe burning sensation.
Exactly. And researchers found that these genetic variations in the burning receptor and the nerve growth factor were significantly more common in women who suffer from provoked vulvodynia compared to healthy controls.
So their genetic code is actually instructing their body to overproduce nerve growth factor the moment they get an infection.
That's the prevailing theory, yes. The genetic variation causes an uncontrolled, exaggerated production of NGF in response to the inflammation of a yeast infection. Their body rapidly builds an excessive, permanent network of raw pain nerves.
That is just mind-blowing. It means that for some women, their bodies are essentially hardwired to turn a common infection into a chronic pain syndrome.
It does.
So could the future of treating this burning dyspareunia move away from swabbing for yeast entirely? Like, could we eventually just be swabbing our DNA to see if we possess the genetic blueprint that guarantees we'll grow excess pain nerves the second inflammation hits?
It's a profound thought to mull over. And more than anything, it validates the reality of the pain at a fundamental genetic level.
It really does.
It proves the pain is structural, biological, and real.
We've gone from looking at a broken X-ray machine to peering directly into the chili pepper receptors of our DNA. If there's one thing you take away from this deep dive, it's that when you are navigating the murky, invisible waters of chronic pelvic pain, you aren't crazy. The pain is real, the tenfold increase in nerves is real, and with the right tracking metrics, the path to an accurate diagnosis can finally become clear. Keep asking questions, keep tracking your data, and never settle for a diagnosis that doesn't fit your physical reality. Thank you for joining us on this deep dive.